So just so everybody's awareness, because this is an open meeting and because we have people joining remotely, we have to record the meeting and post the meeting on DOHH website afterwards. And we have a team that handles that, but. Right. So anyway, thank you, everybody. Welcome to the June meeting of the Mental Health Subcommittee of the Community Services Board. If you were looking for a different meeting, you're in the wrong place, but hopefully everybody's here for the subcommittee. We have a couple introductory slides and then we'll get into the content. Just again, this is mainly for our virtual attendees, but just we ask all of our virtual attendees, and we have to show this slide, Stephanie, to participate actively. Keep your video on, be ready to unmute your microphone if needed, and have your full name displayed, which I think you have all those boxes checked. So thank you for doing your homework on that. This is our agenda. We'll do welcome and introductions. Then we have a quick update on Teen Space, Clubhouse, and then we're going to spend most of our time today talking about the state of mental health of New Yorkers, the mental health report, which our committee members should have nice hard copies already given to them. All right, that's the agenda. Just some kind of quick committee business. We did have reappointments. So Rachel, Scott, and Lisa were all had packets that were detailed, very, I think, somewhat intrusive questionnaires that were filled out. And so then we thank everyone for doing that and getting those in, and we submitted those to the mayor's office, and there's additional steps that kind of happened there, but you should hear back from that. And in the meantime, we welcome you all to continue to participate as if you were members, again, this being an open meeting in the first place. So why don't we start off with having our committee members introduce themselves, and then we'll have our New York City Department of Health and Mental Hygiene employees introduce themselves. Go ahead. Yeah, sure.
Good morning, everyone. I'm Lisa O'Connor. I'm the Deputy CEO of Safe Horizon.
Good morning, I'm Rachel Solomon. I'm a mental health community advocate.
Scott Shapiro, I'm the former director of HIV psychiatry at St. Vincent's Hospital, and I'm a psychiatrist.
Up to you, Stephanie.
Stephanie Lamel, I'm the Director of Public Psychiatry Education at Columbia University.
I guess we'll do DOHMA. So I've been talking a lot already, so I should probably introduce myself first. I'm Jeff DeBerry. I'm a program consultant actually in the Bureau of Children, Youth and Families, but also the liaison to the subcommittee from our bureau, and kind of volunteered to be the facilitator for today, when hopefully I don't do much more talk after this. But we'll just go around or however you want to do it. Go ahead. You want to go?
Sure. I'm Megan Hamway. I'm the Director of Research and Evaluation for the Bureau of Children, Youth and Families.
Ben McCarthy, Policy Analyst in the Bureau of Mental Health.
Jamie Nichols, Assistant Commissioner for the Mental Health Bureau, which focuses on adults. And I'm pleased to pass it over to Dr. Wright.
Morning, Gene Wright from EDC, and my original is from Philadelphia. I've been here since my 7th week, and so I'm glad to be with you. Looking forward to working. Marnie.
Hi, everyone. Marnie Davidoff, Assistant Commissioner for the Bureau of Children.
Right.
You did. Okay. Good that. I'm Rachel Beck from the press office here at DOHMA. That one, the population data for each suicide with the children. Janisha Jackson, I'm mental health data analyst with the Bureau of Justice. I'm Jeff Dunaway, and I'm a project coordinator with Dr. Scientist. Special project coordinator.
I'm Rachel Sass. I'm a research analyst in the Bureau of Mental Health.
I think it's everyone. Yeah. All right. All right. So first, we'll just do a quick update on the Teen Space program from Children, Youth and Families.
I'm happy to, thanks. So I know we've spoken previously about Teen Space. Just as a quick reminder, Teen Space is a virtual mental health service that is eligible for New York City adolescents, ages 13 to 17. It is entirely free. And no insurance is required, payment is required, and care is provided virtually by licensed therapists, so we're licensed in New York State. And teens can really choose how they want to get their care, so they have the option of having a virtual visit with their therapist monthly, and unlimited messaging, which could be by text or audio or video. And we just wanted to share some results from the first 6 months of program operation. So the program launched November of 2023, at mid-November. And it's going to do a few snapshots of what we've been learning to date. So between November 15th, 2023 and April 1st, 2024, 6,800 teenagers in New York City have signed up, and that number has continued to grow. It grows every month. And we're really pleased to see that over 80% of the users identified as BIPOC, and the two largest user groups within that were those who identified as either Black or Hispanic. And we're also really happy to see that we are reaching neighborhoods that have the greatest sort of health and economic disparities. So these were neighborhoods that we identified during the pandemic as we call them the TREE neighborhoods, which is of course our acronym for everything. They were identified by the Task Force on Racial Inclusion and Equity. And we are seeing that nearly, sorry, let me just grab that for you. Okay, yeah, a little over 60% of users of the service reside in one of those neighborhoods. So we've, really feel like we are reaching youth we are hoping to reach from a health and racial disparities perspective. And the neighborhoods that led the city in signups by youth were Brownsville and East New York, Mercy, Morrisania, and Norwood in that order. So from top to bottom. So that gives you a sort of a snapshot of from a racial and neighborhood perspective who's been utilizing the service. From a gender identity perspective, it's pretty striking that, we see that teens who identify as female are much more likely to seek help through this service or space. So almost 70% of the users identified as female compared to 23% who identified as male. Although that is not, it is consistent with national trends, and it also is. We're going to have Megan present in a bit about some of our findings from the State of Mental Health of New Yorkers report, but she'll share some of the gender breakdowns as well. And you'll see, kind of some alignment, I guess, between need and use. And then from the service modalities perspective, we see that, I think, let's see, was over 50% are, so basically, let me start by saying that 96% of all youth using the service utilize messaging as part of their therapeutic experience. Youth can choose to use messaging and or the virtual synchronous visits, right, in any combination. So it's really driven by their preferences. So 96% of them are using messaging. But what was really interesting is that a little over half, about 54%, are only using messaging, and they're not using the virtual video visits with their therapist. And we're learning a lot by looking at utilization patterns of what youth prefer and how they prefer to get care. So this can help inform us as we roll out future programs and continue to tweak this service going forward. Finally, just wanted to share that in terms of early results, and these are early, so we'll continue to track this, but early results showed that 65% of users had already reported some improvement. And just for context, this is measured by some sort of a validated screening instrument. And so the instrument that the youth is given depends on their reason for seeking care. So if they are presenting with anxiety or symptoms that are aligned with anxiety, in a diagnosis, they don't have to be, I should have said that earlier, so reminder, you don't need to be diagnosed to get the service, right? The screen that you will be administered periodically would be the GAD, right? And if you are presenting with depression or symptoms consistent with depression, you will get the PHQ-9. And so 65% has shown improvement in at least one component, one domain of the validated screening instruments that they were responding to, essentially. So essentially a very promising early start. We will continue to track these statistics over time. We will also be conducting a full evaluation. These are the data that are all reported to us by Talkspace, the contracted service provider we're working with for this. And we will also have a third party doing a full evaluation. So happy to periodically update this group as this progresses.
Thank you, Mike. I guess, do we want to do questions?
If we have time, I'm happy to.
And then we'll, I guess, pass it to Jamie for Clubhouse.
Great, thanks. And again, everybody. Clubhouse is a term that's used sort of a lot, right, in sort of plain language, and also in a number of sort of specialized contexts. And for this context, we're talking about clubhouses for adults experiencing serious mental illness. It's an accredited model that's, been around quite a long time, actually, since, the middle of the 20th century. So 50, 60 plus years, I think, since the first clubhouse model was established here in New York City by Fountain House. We have been, I think, really fortunate to have 16 different clubhouses in our city for the last 30 or so years across the 5 boroughs, serving a few thousand adults with serious mental illness. Some of them, they're of varying sizes and varying arrays of services, with a few focusing on older adults exclusively, others serving sort of all adults 18, through the end of life. Some focusing on people with SMI and co-occurring intellectual and developmental disorders. So there were a few specializations across our city, we know that clubhouses provide what is really a life-changing community of mutual support for people experiencing SMI, to gather together, to support one another, to break bread together, prepare meals, work on educational and employment goals, socialize, and move towards their recovery. It's a lifetime model, right? People join and stay as long as they want. They may stay, engage more in services for periods of time, and then, step back a little bit and then re-engage, and that's okay. They're one of the, they're a special sort of place-based setting. And so we saw that community of clubhouses as a critical part of our SMI plan that we released last March. And you may remember we have sort of comprehensive strategy for supporting adults with serious mental illness in New York City, with healthcare, home, right, supportive and affordable housing, community, and crisis response. And so this is really the anchor of the community component of our SMI plan, to give people, again, a gathering place. So we've invested more money to expand the clubhouse capacity that we have by a few thousand, and to provide services in high need areas, which don't necessarily correlate with the places that those clubhouses have been for the last 30 years as our city has changed, and to expand the array of services offered at every site to be more consistent between sites. So there's not, so that every service offers the full array of accredited clubhouse interventions. And so through that, to achieve that, we released an RFP that asked all of our current providers to compete again to continue their clubhouses, and opened it up to new providers for the first time since inception in the 80s and 90s, when these programs were set up. So that process is important, but also difficult, right? As current providers are competing to continue programs and communities where people have been gathering for many years. And so we know that there is some loss to some communities that were not awarded continued awards for their sites. We are working very closely with every program, those that will continue in their new locations, in their current locations with new awards, as well as those that will be closing down with new providers coming in nearby. And so there's variations by clubhouse, right? And 16 across our city. Individualized attention to every clubhouse, especially those that will be closing, to offer as much or as little hand holding and support as the members may want to connect to a new clubhouse community or alternative services. So every person's situation is different, but we want to make sure they're all offered connection to new resources, and that we roll out the red carpet at new clubhouses for them to welcome, come on in, have some lunch, meet the community, be a part of it. So there's a transition phase now happening. The new awards will start on August 1st. It's all been sort of publicly announced. The RFP has been, gone through its course. They're in the process of being registered, their contracts. Any clubhouses that are closing will go an extra 60 days beyond when the new ones are starting, to give a little bit of a cushion there between the old and the new. We'll be ramping up so that we'll start with, existing capacity, and then over the next couple of years, add 3,000 or 4,000 more new members is our goal, with really careful attention to measuring the impact of this service, which we weren't able to do in the current setup. But with the new contracts, we'll have a process for sending more referrals to clubhouses, really making it a part of our continuum of care. We put it in the category of psychosocial rehabilitation services, which is, unfortunately been sort of put apart from treatment, right? Which was seen as sort of primary. And so we're saying, no, like treatment's important. That's great. But we also need the rest of one's life, right? Recovery, employment, education, socialization, sense of belonging. So we're trying to bring Clubhouse into sort of our continuum of care and offer referrals to people as they're coming out of hospitals, often getting connected to specialty SMI services for the first time, offering voluntarily, as inviting people to a lunch at a clubhouse, for example. So that's a part, it's an option for everybody experiencing SMI. Some who will engage and some who will not. So bringing it into the continuum of care and then measuring outcomes specifically around social inclusion, self-efficacy, loneliness, and there's another one, education and employment goals. So we'll have a process to measure that at 6-month increments for newer members, right? This is a lifetime enrollment, so I don't think we'll bother people for the rest of their lives. That seems perhaps overly intrusive, but certainly for a period of years following their initial enrollment. And so we'll come back and report to this group later with those outcomes. Right now, we're really in the startup phase for these new programs.
Can we ask questions now, or are we going to wait
Please.
until the end?
Yeah, please.
Okay. So I guess I have some concerns, as I think many people do, about the Clubhouse initiative, and you've already touched on some of them, which is the closing of the smaller community programs that weren't able to meet the requirements of the RFP, and what's going to happen to those clients that have been going there. But I think the bigger question is, in opening these new programs, is there a community needs assessment being done in the communities that they're opening in, to see whether the new, sort of this sort of cookie cutter model of Fountain House or of clubhouses fits with what the community actually needs in these new sites? And in particular, I'm thinking about the program that's sort of starting in Harlem, which is right next door to a shelter program where a lot of folks have co-occurring disorders. And to my knowledge, Fountain House doesn't really address the needs necessarily of people who have co-occurring disorders. And so there also, the community culture is very, very different. And if you look at some of the smaller clubhouses, they very much reflect the communities that they're in. But to replicate a model that is very sort of homegrown to a particular community and trying to replicate that in other communities without doing a needs assessment seems like it's setting these programs up to not really serve the needs of the community, but more to serve the needs of our systems, and giving us a place to send people, but that may not reflect the community or the community needs. And so I'm just wondering if there is a plan, or part of the startups for these new sites includes community needs assessments and talking to the surrounding communities to sort of find out what their needs are for folks who have serious mental illness or complex needs.
Yeah, thank you, Stephanie. Those are good questions. I think the Fountain House was the first clubhouse, they certainly are, a leader in the space. But there is a sort of an independent, a separate international accreditation that we're adhering to, right? So it's not like we're trying to replicate one organization's program, but I think I hear your point, and I want to make a couple sort of comments about what we're doing, and there's still room, right? There's a lot of time, like nothing is set. So I think there's a lot of opportunity for future input. Clubhouses are really, they're a vessel for the recovery activities and social interactions and peer support networks that reflect the communities they're in, right? I think that is the beauty of them. We want every member to have access to the full array of services. But that doesn't dictate the how, right? And the culture inside, right? That's reflective of the membership, because the model's really light on staff. There's not a lot of staff in a clubhouse by design. The membership run the program according to some, basic structures. And so that leaves all that room for the members to sort of drive the content and the celebrations, the food, the educations, the employment opportunities reflective of perhaps industries and opportunities nearby in those neighborhoods. And so some of the new clubhouses that will be starting from scratch are bringing in members to start to do the design now, right? Because there is not a huge contingency of paid employees. There are and the idea is that those planning activities are recovery promoting in and of themselves, right? They give people an opportunity to come together on something, a joint project, right? That they can see to fruition, setting up a clubhouse, right? Deciding what some of the they call them work units will be within the clubhouse, and doing recruitment within their own social networks and communities. So I think there's a lot of room for the process you describe. We don't sort of say, we don't require a formal community needs assessment, but the program can only run with a community of people to bring it to life.
So then the work units are not set? So
They're set units, but
clubhouse
it's
can
like,
choose their own work units? Is that what you're saying?
it's like culinary work unit, right? So there's some, I wish I had them in front of me, but that's one, because food is a big deal, right?
Mhm.
And then there's like outreach unit, right? The one that calls people, members, to sort of say like, hey, we haven't seen you in a while, you want to come back, right? So the work units are framed like that. So those are not, those I think are open to reflect the people that are participating in them in a way that will naturally sort of adapt to the neighborhoods and the membership across the 13 sites that we'll have. Does that make any sense? I mean,
I hear you. I hear you. It's just that's not the impression that I had based on the RFP and sort of what I'm hearing in terms of the structure that's required for the clubhouses. But yes, if this is not a preset menu, and if people who join will be able to sort of steer the direction of what units they're going to have or not have, and how they, actually implement those units, then yes, that sounds good. I also think that having a sense from the community ahead of time about what the community would like would probably make this more of an organic process as opposed to a preset process. And I hear you, and hopefully this will sort of play out in this way, but I do think that there probably needs to be some effort to actually get a sense from the communities that these are being built and what the community's expectations are or needs are, or what they can actually help collaborate with during this process.
I appreciate all those points and I agree with them completely. I think that those are, that is, what we will aim for and what we will require to be successful, right? I don't think we can be successful without that sort of an input that you're describing. So.
And part of it is also the referral sources, because I heard you say a lot about having places for people to be referred to as they're being discharged from higher levels of care. I think that a lot of the membership in the existing clubhouses are not people who are being referred from acute settings, but are people in the communities who are looking to be involved in belonging to other activities. So it's a very different population if people are all being referred from acute care to the community versus people already in the community who are looking to be involved in, and it's just something to take into consideration that it's going to, that very much is much more of a dictated population than an actual community growth of a population.
Yeah, that's an interesting point. I think, we're adding that referral stream, which wasn't there before, but I think we'll continue. I know clubhouses will expect them and they will continue to engage directly with their communities. So it's not limited to hospital discharge, for example, which is an opportunity, I think, to offer people, just support at a time of need, right? And to connect with people who maybe have done that in the past, who have been hospitalized and are now, at a different place in their own recovery to provide that mutual support, right? So we were thinking about bringing those two groups together.
Right.
Who I wasn't thinking of as sort of separate. I was thinking of those sort of people at different points in their recovery.
Right. So to that point then, and I don't mean to go off on a tangent on this, but I think
this is an important issue.
If we look at PROS programs were initially designed with a similar kind of idea that we would have recovery-oriented services around education and employment and other sort of, more socially driven components, recovery-oriented components. And PROS programs, again, this is completely anecdotal, but I think that when PROS programs started to be the default programs for people who were coming from acute care settings, in terms of where they're being referred, it very much changed the culture of the PROS programs. And I think that the acuity of the folks people were much more acute, so their ability to participate in a lot of the more recovery-oriented things shifted. And I'm not saying that it's right or wrong, but I think it's something that we just need to think about. That, if we're going to be, if we're using this as a direct referral from acute care, that it's going to be a different type of program than what clubhouses currently are. And I mean, we need it, but it's just something to take into consideration. And so that ratio of folks from the community who have already been getting their care in the community and are coming here for social reasons, it's very different than people who are coming from an acute care setting and are trying to sort of reintegrate back into the community. It can be done, but it needs to be thoughtfully done. And the needs of these two different populations are different. And I think that needs to be thought of and built into the clubhouse's capacity if they're going to be taking folks who are more acutely in need of structure.
Those are great points. I really appreciate that. That sort of line of thinking. I think we can talk more with the providers about that. I think those are good points. Thank you.
Jamie, I have a question. With the history of clubhouses, is there any research about the clubhouses that have more paid staff versus the ones that are run more by the members?
So I think I haven't seen research about that. My experience is that they're fair, that at least across our current contracts, they're all lightly staffed by design. So I haven't I haven't seen much differentiation in the proportion of sort of membership to staff to notice if there's a difference. There's workforce challenges everywhere. And so I think we're sort of eager to sort of bring people in or interns and have people come through and sort of experience that sort of work and then sort of, you know, stay in that, in the field and work in clubhouses or sort of move on and sort of, be advocates for the model in other spaces. So I think there's been workforce challenges generally that I haven't seen that many places that are, you know, staff rich. Does that answer your question?
We have a lot, we have a mental health report too to discuss. This is a good discussion here and we want to probably keep this level of engagement going as we get into really our detailed mental health report. And so if everyone's okay, I'm going to move to the next kind of talk. Yeah. All right, so the state of mental health of New Yorkers, and I'll pass it to Rachel and Megan to kind of give an overview, and then we'll talk about the discussion questions. You should have the discussion questions like already in your packet, and it's going to have those in mind, kind of go through. Yeah, go ahead. Megan, if you want to just. You want to do this? You want to do it? You want to switch? Sure.
Yeah, whatever.
Yeah.
Whatever makes it easier, so you don't have to do the next slide, next slide. You know, hearing that constantly.
Yeah.
All right. These were the prompts that Jeff was just mentioning that are in your. Okay. So again, I'm Megan Hamway, Director of Research and Evaluation for the Bureau of Children, Youth and Families. We're very excited to present our mental health to you all today. It's definitely been a labor of love and many tears. So hopefully you enjoy it and it's a good read. So we wanted to start by giving an overview of the goals, right? So the entire purpose of this report was to really develop a comprehensive report that details the state of mental health for all New Yorkers. And we wanted to do this using our most current data as well as many of the data sources that we have available, so not just one. And of course, because that means all New Yorkers, we're focusing on many ages. And so in order to organize, it's really difficult to organize around a concept. So we've decided to take a lifespan approach. So you'll notice in the report itself, it starts with children, moves into teens, and then on to adults. And then, of course, that's covered with the introductions and our conclusions as well. So that being said, I'm going to start by discussing some of our findings around children in New York City and their mental health. But before I do want to just mention the caveat that for this presentation, we are certainly not including all of the information that's in the report. It's much more comprehensive. We're just pulling apart some of the key findings for you all today. So to get us started with children, so children in this report include those who are between the ages of 3 and 13. And the data for this particular age group comes from our New York City kids surveys, the 2019 and 2021 specifically. And those surveys are biannual surveys conducted by the health department that parents complete. So findings from this, we did find that a higher percentage of parents and caregivers of children ages 3 to 13 have reported concerns about their child's development in 2021 than in 2019. So we do see an increase there. And in both 2019 and 2021, the numbers remained fairly stable, with mental health diagnoses being identified at a rate of 15% amongst those, and that included anxiety and depression, those types of diagnoses, with anxiety being the most common diagnosis identified. And then when we look at adverse childhood events, we did identify that an estimated 291,000 children ages 3 to 13 have experienced anywhere from 1 to 3 adverse childhood events. And another approximately 30,000, or about 2%, have experienced 4 or more adverse childhood events, which can be extremely challenging and difficult for one's mental health presently and in the future as well. So again, lots more information on children, not to de-emphasize children by any means, but just for the sake of time, I'm going to move us into the teen portion of the mental health report. So the data in this section comprises about 2 data sources. We look at the Youth Risk Behavior Survey, which is specifically the 2019 and 2021 years, although there are some trends in there that look at 10 years. And we do also report on a new data source, which is the Family Mental Health Survey, which we conducted here at the Health Department in fall of 2023. So to start, not to start on a sad topic per se, but really getting into the mental health components. And this is on page 15 and page 18 of the mental health report if you want to reference it. We're talking about sadness and hopelessness and depressive symptoms amongst teens. So between 2011 and 2021, there was an increase, you can see, from 27% to 38% of New York City public high school students who are reporting feeling sad or hopeless. So we're seeing quite an increase over time. And when we look, if that's on the left-hand side here, so if you kind of go to the right-hand side now, you'll see some of these gender identity discrepancies. So girls in New York City tend to have poorer mental health outcomes compared with boys. And among those New York City public high school students between 2019 and 2021, we see that there's an increase in the percentage of girls, and in fact, about a 4% increase, whereas for boys, we do not see a change. The number is exactly 28% for both of those years. And then if you look in the center, we're talking about our depressive symptoms. So those two data points on the outside are from our youth risk behavior survey, and the center is from our new survey, where we actually asked about symptoms. And what we found was that amongst teens that identified having some type of depressive symptoms, 48% report minimal to no depressive symptoms, whereas 27% report mild, 14% are moderate, and 11% are reporting that they have severe depressive symptoms. So next, talking a little bit about coping and resiliency. So the most frequently endorsed coping mechanism, that was used by teens in our 2023 data were listening to music. So that's very common, as well as using social media. Some negative coping skills were also identified, where youth were saying that they criticize themselves a lot most frequently or blame themselves a lot for things that happened to them.
Is this in the book? or
Yes, this is on page 20. It begins on page 20 of the report.
We can go back, so when we do discussion, if you want to write down and go back to the specific slide.
Yeah, absolutely. And in terms of the resiliency levels, few teens report actually being highly resilient at only 8%. Whereas in 2023, the majority of teens were reporting a medium or like a normal level of resiliency, and 30% were reporting low resiliency. So there's clear differences that exist here. And we're also seeing those differences based on sexual orientation and gender with girls, which is not pictured up here. But those who identify as a sexual minority or being, they're more likely to report low resiliency, whereas boys who identify as heterosexual were more likely to report high resiliency. So we're seeing some discrepancies there as well. And then in terms of access to care, this is a critical area because we're across most of the surveys at the city, we're constantly asking about access to care, needing care, and are you able to receive that care? So what we found was that nearly 1 in 4 teens said that sometime in the past 12 months, they needed or wanted mental health care, but did not get that care. Now, talking a little bit about these stressors, we report on a variety of stressors in the report. Again, this is on page 22 to 26 and 27 of the report. Between 2011 and 2021, you can see that there's an increase in the percentage of New York City public high school students who report electronic bullying. And that younger students, especially females and LGBTQ plus students, were more likely to report electronic bullying years. And although around 1 in 3 New York City teens said they did not experience discrimination, which you can see on the right-hand side, the questions that the topic areas that we assess discrimination around, 34% of those, said that they did not experience some form of discrimination. The bottom line here on the visual, another 35% said that they had experienced discrimination, specifically based on their race or ethnicity. And racial and ethnic discrimination was more frequently reported by Asian teens at about 50% than any other group in the survey. Also of note, that's not up here, but again is in the report, our findings surrounding social media use, a big topic. So about 58% of the teens who were responding to social media questions indicated that they had both positive, social media had both positive and negative impacts for their mental health. So we're seeing both sides here. Finally, in terms of youth suicidality, so this begins on page 29 of the report. Thankfully, the percentage of suicide attempts among New York City public high school students has remained stable over the last 10 years. So we do not see a change since the COVID-19 pandemic. However, in 2021, New York City public high school students who had seriously considered suicide in the year before the survey was taken were more likely to be female than male, and more likely also to be Latino than white. So I know that was a lot of information. And again, there's a lot more in the report as well. We do have some summary points available. I don't need to read through each of these for you by any means. It's really reiterating some of the information that I already shared with you today. Just wanting to emphasize that we do have quite a bit of information on both these age groups in the report, and that we are seeing some pretty substantial differences. And in fact, I'll go back to the beginning and read for you the quote from the commissioner to really reiterate the importance of this report. And what he said was, what we see in the data is that mental health is neither static nor homogeneous. We see a deep crisis in some communities while observing relative wellness in others. We see an evolving post-COVID-19 picture of New Yorkers recovering from some of the worst impacts of the pandemic and longer-term effects still developing. This report represents a landmark moment, the start of a process where the city's mental health is routinely reported on as a civic responsibility. So we're hoping, just to reiterate that's exactly what this report will be doing throughout. So with that, I will pass to my colleague, Rachel. Yes, sure.
Thank you, Megan. Okay, so again, I'm Rachel. I'm a research analyst in the Bureau of Mental Health, and I'll be presenting on our findings from our adult New Yorkers. So that's those aged 18 and older. Okay, so the first outcome that we will look at, and this is on page 41 of the report, is serious psychological distress. So serious psychological distress, or SPD, is defined as having a score greater than or equal to 13 on the Kessler-6 scale, which is a 6-item scale developed to identify people highly likely to have a diagnosable mental illness and associated functional limitations. However, SPD itself is not a diagnosis. It's just a good way to understand how large groups of people have been feeling in the past 30 days. So if we look at SPD over the years, I want to note first that these surveys use different methods, so change over time should really be interpreted with caution due to differences in survey sources and methodology. We see that in 2019 and in 2020, the prevalence of SPD in New York was around 5 or 6%. And then in 2022, we saw a prevalence of 14%, possibly showing the negative impact of the pandemic on mental health in New York City. And then in 2023, we had an estimated 541,000 adult New Yorkers, around 8%, having SPD. So again, surveys use different methods, but this data may indicate that the mental health of adult New Yorkers seems to be somewhat improving post-pandemic. Another key outcome, as Megan mentioned as well, that we look at is mental health treatment, here defined as receiving counseling and or medication, and then also perceived unmet need for treatment. So looking at New Yorkers with serious psychological distress, the outcome we just discussed, about half, 52%, received mental health treatment in the past 12 months. And you can see the breakdown on this donut chart of those receiving medication and counseling, counseling only, medication only, and then that 48% of New Yorkers with SPD not receiving medication or counseling. We also report on perceived unmet needs. So here it's important to remember that unmet need is self-reported. It's people's perception of not receiving as much treatment as they would have wanted, not receiving it as soon as they would have wanted, or not being able to access it at some point when they wanted it. So because this is unreported, self-reported, it's also tied to factors that influence which groups of people perceive their need for treatment or want to pursue mental health treatment. So it's possible that some groups can report both higher levels of treatment and higher levels of unmet need. In 2023, we saw that 46% of adults with SPD, so nearly half of adults with SPD, are reporting an unmet need for mental health treatment in the past year. And some of the barriers or the reported reasons for this unmet need can be found in the report, I believe in page 53 or 54. And then another really important outcome that we've been discussing a lot recently is social isolation, which is here defined as feeling cut off or distant from other people, somewhat or a lot in the past 4 weeks. So in 2023, we saw that 40% of adults are reporting feeling socially isolated. And this is really important because social isolation has been highly associated with serious psychological distress. And New York City adults who report feeling socially isolated somewhat or a lot of the time are much more likely to have SPD than those who do not feel isolated. You can see on the right here, almost half of adults, 46%, who feel socially isolated a lot of the time have serious psychological distress. Only 1% of those who say they don't feel socially isolated at all have serious psychological distress. So now we're going to shift gears a little and look at some of the key breakdowns where we see some inequities or differences in mental health outcomes in our data. And so we're going to focus on 3 breakdowns: age, gender, and race and ethnicity. So first, looking at age, across the board, a general pattern we saw was that older adults, those aged 65 and older, had better outcomes than other age groups in several areas, while young adults, those aged 18 to 24, are experiencing poor mental health outcomes. So we see, starting in the top left corner in the orange figure, adults aged 18 to 24 are more likely to experience serious psychological distress than all the other age groups. In the middle top, we see that among adults with serious psychological distress, adults aged 18 to 24 are less likely to have received mental health treatment, again here defined as medication and or counseling in the past year, than all the other age groups. In the top right, you see that among adults with SPD, again, adults aged 18 to 24 have higher self-reported unmet need for mental health treatment than the 2 older age groups, 45 to 64 and 65 plus. Moving down to the bottom left, an outcome we haven't touched on yet is psychiatric hospitalizations. So many adults experiencing mental illness are not hospitalized, but hospitalization may help stabilize people experiencing worsening symptoms. And while psychiatric hospitalizations can indicate need or burden of mental illness, they also reflect the adequacy of non-hospital community-based care and access. And in 2021, we saw that younger adults, again, age 18 to 24, had the highest rate of psychiatric hospitalizations at 1.5 times the overall citywide rate for adult New Yorkers. Finally, back to social isolation, we saw that young adults aged 18 to 24 were more likely to report social isolation than other age groups. Again, 50% of those of adults aged 18 to 24 reporting feeling cut off or distant from other people somewhat or a lot of the time in the past 4 weeks. Now we'll look at gender identity. So to start off, people who don't identify with the gender they're assigned at birth may experience discrimination and transphobia, and these stressors can increase the risk of poor mental health outcomes. So you see on the left that transgender men, non-binary or genderqueer people, and those with another gender identity not listed here are more likely to have SPD than cisgender people who are identify with the gender they're assigned at birth. On the right, we also see that adults who don't identify as cisgender man or woman have significantly higher self-reported unmet need for mental health treatment as compared to the reference group here of cisgender men. And finally, looking at race and ethnicity. So we see, so we know that structural racism is racial bias across institutions and society. It's It's a system of structures, institutions, and policies that work together to advantage white people and disadvantage people of color. And structural racism has a harmful effect on mental health. We see in the middle in the blue that adults who sometimes, always, or often experience discrimination because of their race and ethnicity are more likely to have SPD than adults who never or rarely experience it. On the serious psychological distress chart on the left, we see that Black, Latino, and Middle Eastern or North African adults and adults who identify as multiple races are more likely to have SPD than white adults. And on the right, we see here that white adults have higher self-reported unmet need compared with Asian, Latino, and adults of another race and ethnicity not listed. Important to think about is that while SPD range from 7 to 13% across different races and ethnicities, unmet mental health need among people with serious psychological distress has a bigger range. It ranged from 32% to 63% across race and ethnicity, reminding us and suggesting that cultural norms around mental health needs and treatment and structural barriers to treatment access vary significantly across people with different race and ethnicities. It's a summary slide. As Megan did, I won't read out all of them. It's everything I already said, but I'm happy to answer any questions, and I think we can review the discussion points as well that were shared. Yeah.
Thanks, Steve. Yeah, thank you for that presentation. There's a lot to take. So we don't, how much we have, just to give a quick time check, we have about half an hour. And like we said, the plan for this was to just, dump as much of the information to you as possible to gently, I guess, give it to you, give it a few minutes to kind of digest as we're going through. And then we really have some discussion questions that we wanted people to think about as we were going through, or certainly it's not already, then to start thinking about them now. And I'll put them back up on the screen. And the idea, really, think first about, from your perspective in the community and the constituents that you serve. And, what does this mean, or how does this compare to what, you're seeing in your communities? What does this, mean for us as a health department? Like, what should we be thinking about short-term and long-term? How can we respond to some of these findings? And what does that mean for us as we kind of continue to develop the mental health system in New York City? So those are really that's the kind of the conversation that we were hoping to have, based on the information we just presented, but.
May I ask a clarifying question?
Yeah, sure.
And both of you hit on this in terms of the unmet needs reporting of self-report. And obviously I just got to New York, but in Philadelphia and other cities that I've worked in around the country. There is a difference between disparity and access, meaning not available in your zip code and people choosing not to access what is available. So when you talked about the unmet need and how it is reported, do we have any sense of how we may ascertain where people, what categories people are falling into? Is there certain zip codes in Philadelphia where the providers are there, the treatment is there, people choose not to access it because of socialization and cultural norms and things that they don't trust the system, or they don't trust the people in the system. Why? Because systems are made up of people, and people talk about, the system of structural racism, but people make up systems. So if you're not receiving what you hope to receive, you may choose not to do so. Or you may have previous negative experiences in your family, in your history, you may choose not to access. So in terms of driving us, DOHMH, into how we can be more helpful in terms of getting treatment or making it available, was there any back information that you can share both on the adolescent side and children and on the adult side that closes that gap on the identified as unmet need? You described the unmet, self-assessment perfectly, but just wondering if it's taken into consideration those cultural norms and those challenges that happen to be in BIPOC communities.
Do you want to start, or do you want?
Oh, sure.
Yeah.
So, at least from the youth side, the current data is asking about the unmet need, and it's not necessarily from one perspective. It's my interpretation would be that we're asking about, like, you chose not to get a treatment. Not, we don't have any way of discerning that it was because it wasn't necessarily available in that area for that individual. Right now, a lot of the data that we have available, we can look at by like borough level, so it's really not granular enough to get that close. Our newest data might be able to get us a little bit closer to that.
Yeah, I think it'd be interesting to know that I wanted it. I tried to get it and I couldn't. No.
And there's some kind of proxy for that in here where people are described, like, I can handle it on my
Yes.
own.
Yeah,
I just can't seem to find.
So on,
Page 30 has.
that's for the youth. So on page 56 for the adults. We have, so we asked about barriers to mental health treatment. And I'm hoping to publish more detailed information on this later this year, maybe. But yeah, so we provided a few categories. So you can see actually that the most reported reason for not receiving mental health treatment is that they thought they could handle their mental health without treatment. That's 50% of those who are reporting that unmet need variable are reporting that they thought they could handle their mental health without treatment, and that's why they didn't access treatment. And then the next most reported reason is they couldn't afford the cost. And then the third most reported reason is did not know who to contact or where to go. So that's really, I think, meaningful for
Absolutely.
our activity and what we do with that information. And then we also had an other barrier, which was an open response. And so they were allowed to write in other reasons. And I've been working with my team on doing qualitative coding of those responses and creating new categories. And we are seeing, like, I didn't trust the system. I've had previous bad experiences, things like that, which are, I think, will be really interesting to look at where people are reporting that, who's more likely to report that. And can help really inform our activities as the health department.
Absolutely.
I think what's interesting about that finding is when you look at the data for teens specifically, it shows the kind of reliance on family to make those connections. And then I was thinking back earlier to your presentation on teen space and how that is an option that kind of helps us navigate that complexity, that if families are not aware of situations, then some young people are not going to get access. But how do we make sure that they are aware of those things that their family do not have access for them? Feels like an important part of what else is needed.
Mhm.
Yeah, on the adult side, on page 45, we can also see sources of support, and the most reported source of support for mental health in the past year is a close family member, friend, or loved one. And that's 34% of people are reporting that's their source of support. And I think, that points to, like, the need for things like mental health first aid training, right? For people to know how to respond or know what services are available when their loved ones do come to them.
And what I'm reading now is that even though the city has done a lot of marketing, so communities, it's still not being met. How it's definitely regional. And I'm looking at Queens, and I was surprised to see like 50-some%. 76% of those that meant treatments. So what can we do different? I mean, like, so we go about this differently. We did the marketing, the hospital, HSC, different languages, but still it's not being met. And I'm gonna I think, what can we do to get those, people have access? That's one reason why I got involved, deny of access for people of color. And I'm so, it hasn't flowed. I'll say that's 10 years ago, it's worse than this. But I'm still surprised that that is very high percentage of that these cause of access. Like once people understand that there's care, they can realize they can afford it. Sometimes they realize I can't afford it, my job or whatever. They don't have the information So I'm trying to, what more can we do? We're not doing it. Something is missing.
Yeah, and I think some of that is like, this data is an important starting point, right? Where we were just talking about with the barriers, like, why are people not accessing the care?
Right.
And having that drive our decision making and who is not accessing the care and where exactly, and really basing our actions on that.
So are we talking now about question number 3? Like how can DOHMH respond?
Sure.
And that's, I think that's a great one. But I just want to make sure that
Yeah,
We didn't have a formal structure. We were
Yeah.
gonna do one
Yeah.
question at a time, like certainly if any points that you wanted to raise.
But would it be helpful, people think, you know, maybe just to brainstorm about, you know, we've got the information that there are unmet needs, you know, whether people are accessing or whether they're not. And, you know, in my experience and just from these meetings and from the research, a large reason for the unmet needs is, you know, multifold, but is because of lack of providers, a lack of resource. I'm just wondering if we should brainstorm, you know, what this department could do to kind of increase services, you know, knowing that a big part of it's lack of services, you know, would that be useful for us to?
yeah, and I mean, this might be more Ben's expertise, but there are policy recommendations at the end of the report that I think speaks somewhat to service delivery, workforce, and things that are pieces of getting at that prevention.
And feedback that you have now, I mean,
Okay.
brainstorm, of course, we brainstorm on this, I think, we have to speak on behalf of the department, but I think
Yep.
there's probably a lot of brainstorming that's going on, you know, every day on this. But the feedback that you have or input that you have, that could help inform that, but I think what we're looking for here.
And I think that's what we're, so we want to do in
Yeah.
all the sort of, on the adult side that I was talking about, which is for us, or my bureau in particular, a serious mental illness, which is a little different than SPD, right? But I think we're looking to expand services in each of those areas, health, home, community, response, so that there's more options available to people, taking advantage of new sort of federal and state investments and things like CCBHC, Certified Community Behavioral Health Clinics, which we hope will sort of greatly expand treatment capacity and make clinic care sort of a little bit more robust and more accessible. And then we've added a lot of spots for mobile treatment services over the last few years, a few thousand more, but there's still, wait lists, right? There's
still wait
almost,
lists.
yeah, there's still wait lists, no matter how many more spots we add. There's just such a hunger and a need for the services. And so something like Clubhouse is, I don't want to go back and spend too much more time on that, but it's a way to reach a lot more people without, relying on a lot of providers, right? Creating a space for peer support, really, to work and provide sort of non-staff intensive opportunities for peer-to-peer connections and recovery. Hopefully that's amplify, the reach
Right.
of the system, right? But not in a sort of traditional treatment, one-to-one provider to patient ratio. So that's why we're trying to think about those sorts of ideas.
I think that those help with, and Stephanie, I would love your input as well, and Marnie too. I think that those help as ancillary services. But, I think, and Rachel, what you're talking about too, is that it really is, in addition to the clubhouses having clinicians, people who don't have, the 40%, the 50% who don't have access beyond just they don't want to access it because stigma or for other reasons, but because of lack of access.
Mhm.
And for strategy, for things that DOHMH can do to increase, the floodgate of need.
I do think there's something to be said about, we're just looking back at this kind of barriers idea and people not knowing who to contact feels like an issue, then I'm also hearing that there's actually not enough capacity. And so for me, it's how do you build more capacity in those places that people are already connected to? Because if you're constantly trying to draw someone's attention away to something new and big and different, you're not actually addressing their needs. Like when I think about the work that in our homeless youth work, that we try to make sure that everything that young people need is in sight.
Mhm.
And so that they don't have to travel a lot to different places to access what they need. And so for me, it's how do you create capacity in places that people are already connected to and not ask them to go to someplace new, because that in and of itself becomes a barrier. And so for me, I would love to hear more about how are you connected to other components that are already providing some kind of service to a population, and you're expanding their ability to interact with young people or adults who need mental health support, as opposed to adding capacity in these other places that people aren't going to or don't know how to get to anyway. Right?
Mhm.
They're getting support somewhere. How do you connect more to those things?
Yeah, I mean, I think, it is, great point. I think about integrating care, especially well, not saying as opposed to for the adults, but I think it definitely can say that it is a needed strategy for young people for all sorts of reasons, including, and in the data, and Jamie always points this out, and Rachel does as well, like the data on the transition age youth is incredibly striking, and the way we divide this is like, even though sometimes our services on the youth system go up to sometimes 21, sometimes 24, it's not always consistent, right? From a population perspective, right? We do 18 and under 18 for, in the youth section, and then 18 plus on the adult section. So the 18 to 24-year-olds, you can see it gets compared to other adults, right? And when you compare them to other adults, it's striking on every single measure. They're doing worse, and Jamie speaks about this a lot, right? And we know that like our systems don't do well by transition age youth because they're betwixt in between, right? Like, but I was thinking about that group specifically because older youth in particular don't want to get care often in mental health labeled settings, right? They want to have it in stigmatized settings. That speaks even more strongly to building it into places where youth are going already, I also think that with, and it's interesting to think about, some of the conversation earlier about, even with clubhouses, like, for youth and adults, right? Those who have a more serious mental health need, right? And have been identified as having that need and already in the system of care versus people who have, maybe their needs are not as intense, right? And sort of how do we accommodate both in the service system, right? So I think that for the first group, I think there's also this growth of these CCBHCs, which I'm always, Jamie, help me out, that they're the community, I always mess up.
Certified community behavioral health
Health
clinic.
clinics, right, which are
I think-
trying to integrate care into a setting. Tending, I think, to be a little bit more in line with serving holistically the needs of people who've had a more serious identified need or persistent need, right? And then I think that the opposite direction is integrating the mental health care into primary care, pediatric settings, drop-in centers, right? Like places that have recreation, that are not just health, that holistically need, right? So I think that, both are needed and might potentially be reaching overlapping, but maybe slightly different groups might be drawn to each of those in terms of acuity and persistence of their mental health needs. So
Where are the 24-year-olds going?
yeah, no, we have a lot to do on that. Yeah. Sorry, Stephanie. Yeah.
No. Finish what you're saying.
No, please. I was just thinking out loud. You've got the floor, Stephanie.
Yeah, I guess I think about this sort of from a public health perspective. And I think, you have sort of primary prevention, secondary prevention, and tertiary prevention. And if we're focused on treatment, then we're sort of way down the line in terms of approaching systems to provide actual treatment for people. Where I think a lot of the stress that people have is upfront to sort of being diagnosed with an illness that requires treatment. And there's so many other things that I think we could be focusing on in the primary prevention and in the community engagement. And and, you know, like I'm thinking, particularly if we're thinking about the child world, like the New York Children's Center, you know, where they are actually embedding, and I think this is what you were, I'm sorry, I don't know who was just talking because it's hard to tell from Zoom, but, you know, of embedding behavioral health services, not just treatment, but wraparound services in the places where people go, right? So that's the model that the Child Center is sort of doing, where they're actually embedding clinical services in programs, not-for-profit organizations that provide legal services and other social support services and other things besides treatment, but they're also including that by embedding treatment programs in social support programs. I mean, there's a lot of literature about engaging people through the, you know, spiritual and religious settings. So churches, synagogues, mosques, and having sort of more mental health awareness, being financially supported in an educational way and in a treatment way through places where people go, community centers, after-school programs. And you're right, the question of where do sort of young adults go?
Yes.
Part of the problem with young adults is that they're out of school and they're unemployed. And so trying to do this through employment, and it's not just, so employment programs are about getting a job, but also employment programs could potentially be a way of engaging people around their own health and stress reduction in a preventive way. So I think that trying to grow those types of services, employment services that are not just geared on just getting a job, but also helping the person understand what needs to be in place in their lives for them to actually be able to sustain a job, might be a way to engage that age group. And just other meaningful community activities. And I agree that, you know, having clubhouses is a model for people with serious mental illness, but we don't really have a similar model for people who have common mental illness or who are stressed. And having more community funding for community activities and a mental health presence in community centers might be a way to start to try to address that in an upstream preventive, you know, public health approach to prevention for folks who don't have the level of need of actual treatment, if that makes sense.
Makes a lot of sense. Thank you, Stephanie. Yeah, and like, you know, continuing to me, that speaks to the need to continuing to partner with, and a lot of the other city agencies are embedding mental health into what they do, but you know, it's not their core mission, right? So how partnerships can we strengthen their efforts? So like with DYCD, for example, or, you know, right, ACS, right? We partner a lot with ACS. And originally DYCD, I was actually just for teen space, had the opportunity to meet with their employment providers, and then their Compass or after school providers. And it was just on teen space, right? Which is great. And it's a start because we want all the folks who work with young people to know about this resource, but that's one resource, right? And that's different than embedding, you know, care into some of those after school programs and employment programs, et cetera. Because we know they touch a very high number of lives of young people in New York City. And it's through those partnerships, I think we can have the greatest reach. So I totally appreciate your point. Yeah.
I think one of the things that would be helpful is changing the language. One of the things we did in Philadelphia, we don't talk about treatment and therapy and counseling with that 18 to 24-year-old group. We talk about healing spaces, coaching, life
Coaching,
skills.
yeah, is a better word.
Those are words that resonate more with that age group. Yeah, we don't even mention therapy, counseling, treatment to that age group.
Coaching and what else?
Healing spaces, life skills. Because if you look at the surveys, in terms of what teens are saying, in terms of how they're showing up and what is missing, they are open to saying, hey, I need to live a better life. I don't know how, you know, and so that life coaching sounds better to them. Doesn't come with a diagnosis, doesn't come with the same stigma, and you set it up in spaces that are not called clinics, right?
Yeah, that's exactly it. That's exactly the point.
I think part of the work that happens there and what we've done a lot in our domestic violence shelters is kind of training staff to do screenings in very basic language. Right, so we do a lot of trauma screenings because of families coming in with different needs. And it's not that you have this checklist, but you're having a conversation, and through the conversation, you're learning about, is someone having sleepless nights? Are they having intrusive thoughts? But you're learning that through basic conversations. I do think that's also a component. Like, you can't not call treatment and then actually behave as if it's a therapeutic environment that has this very clinical structure to it. So I do think those things are also complementary.
Yeah, and to Stephanie's point, if I can get you into the space that is comfortable for you, and you said the same thing, and then you connect to services and socialization that is helpful, and then we identify something. Now I have a relationship with you. Now we can talk about treatment and therapy, you know, because now all those other things, I didn't start with that with you, because then I would have lost you. We started with things that you wanted, needed, and resonated with you, and now we can talk about those things. So it's an ongoing approach, I think, that we need to do this and implement.
And before.
Stephanie,
people
what
are
I like
in a
about,
crisis-
go ahead.
No, I was just saying, and before people are actually in a crisis. So that you
Yes.
can actually do more crisis prevention, which reduces stress, which can reduce the onset of illness and can maybe avoid illness for folks who have, you know, illnesses directly related to all the stressors in their lives.
The whole point of addressing social determinants of health is to know what those are. Poverty being a huge one that impacts all that, and meeting people where they are and giving the community resources. You know, communities have been divested. Some people have disinvested in community. So returning those resources, now we can meet those Maslowian needs, right? As we work our way up the pyramid, that would be return some community efficacy back to the communities.
No, what I like about what you're saying, Stephanie, what you're saying is, you know, being where people are at. And, you know, psychoeducation can go a long way. So whether it's at community centers or spiritual centers or at senior centers, you know, getting there and having people provide psychoeducation, people can learn quite a bit. I mean, some of these, when people have workshops at the library or at community colleges about, you know, life skills or, you know, positive psychology or how to, you know, feel better. Those are popular and people can access it, and you can reach a large number of people.
Absolutely.
And I think from a realistic perspective, that's where DOHMH can probably have more of an impact, because, you know, we can't increase the number of, you know, clinicians, and we're not going to necessarily be able to mandate how clinical services are triaged, but we could potentially sponsor and support more community activities embedded in existing programs. And I mean, I actually was thinking about this. I don't know, and maybe you guys can answer. Does DOHMH have any interaction with community centers throughout the city?
We do.
I mean, what, Stephanie, what type of community centers were you thinking of?
Like local community centers. So like I know, I'm blanking on the names of some of them now. There's some that are located near some of the NYCHA housing programs. There are community centers.
Okay.
I mean, obviously, like YMCAs and YMHAs, all of the sort of easily accessible community agencies that provide activities or gyms or preschools and you know, preschools that are linked to sort of other religious organizations where the parents may be coming on a regular basis. What are some of the other programs? These are the ones that are just popping into my head right now, but I'm sure that there are probably many that I don't know of.
No, you're right. Yeah, most
Sometimes they're
neighborhoods
linked-
have the community centers.
Right.
The community centers and senior centers throughout
Right.
throughout the city.
Yeah, I don't know if there's any one title that captures all of them, but I
Yeah.
think there are lots of different programs within communities.
Yes, got it. Thank you. I didn't know if there was like a designated sort of type that you had in mind. Yeah.
No, just in general,
Yeah,
in general.
yeah. Yeah, no, it's a great suggestion. I think we should look more closely, right, at where we are and where we're not. I think that's a really good way, a really good lens for us to take a look at where we're present when we think about, different types of community engagement and integration. I mean, one thing that we do have are these health action centers, which partner with community-based organizations and they co-locate them. So there's like a bunch of different community-based organizations that are in each health action center. That's a little bit of a different model than you're describing, which is that there's a pre-existing community center that we as a health department embed into. It's a slightly different variation of that. But I completely hear your point. I think that's really important.
Can you say a little
and,
more
yeah.
about that? Though, what are the action centers that you're referring to?
Yeah, there's health action centers in probably 3 or 4 neighborhoods I have to think about. They're located in some of these tree neighborhoods. And they vary, like what community-based organizations are on site vary depending on the needs of that community, right? And they're really welcoming spaces for people to come in to get sometimes direct services, to get health education, psychoeducation. They're not mental health specific. Although mental health is part of the needs that often get met in a more preventive way, right, as you were describing, in these settings. And so it's I think attempting to do very much the spirit of what you guys have been describing here, which is to really have a community embedded site that is really for the community and shaped around the needs of the community, and has a constant presence and engagement with the community. So it's not just when there's a problem, right? And offer all sorts of services. They have like family wellness suites where there's all sorts of services that, parents of young children can get for themselves and for their children. There's like all sorts of services, and we can send around, why don't we put that in the notes? We can send around links so you can read more about what they are and what's available on each one of them. So it's just one example, but I think your point is really important and we should be looking more holistically, right, about where there are other touch points. And I don't know, Jamie, I've been sort of speaking from more from the youth perspective. I don't know if there was anything you wanted to add on that.
There's a New York City Aging, the city agency that focuses on older adults, and they have an astounding number of senior centers, right? It's like a couple hundred. I was shocked by how many there are. And there are mental health clinic satellites co-located at a number of those senior centers, as just to do exactly what we're talking about here, right? Where people are, and offer them sort of a gentle sort of transition into treatment services if they want, right? But there's also this sort of standalone senior center for community. And I just remain so surprised by the improvement on every mental health indicator over time, by age, right? With older adults looking better than young adults on every single indicator in this report, right? Social isolation, which is really the biggest concern I think we had here at the health department about the mental health of older adults during COVID, right? When they were sort of trapped at home, couldn't use that. We're like, how are they going to use Zoom? How are they going to we were so concerned about that. And look at that, like they were the least socially isolated group during that time. So I think that's reasonable to think like the investments we've made in older adults are working in many respects, right? And we should also not as an alternative to not like moving resources from older adults to young adults, but we should also bring resources to the young adult population, to 18 to 24 in particular, seem just so much in need of resources. Why are there no community centers for that group, right? Where those folks feel a warm welcome.
Yeah, I think we need to be intentional about asking the question that Stephanie asked, which is, 1, can we identify the community centers? And 2, the DOHMH involved. I know we're involved in many other faith-based organizations because they've been calling me since I got here to set up meetings, which I'm going to. But that tends to affect the older adult population, not the 18 to 24, right? So I would want to be intentional about asking the question that Stephanie asked.
Yeah. Like, I
We'll
don't
get
know.
back to you, Stephanie, with an answer.
Thank you. And I'm wondering, are there, I'm sorry.
They go to church for different reasons.
Yeah, that's true too.
That's why, again, I can only reference Philadelphia right now. We created service opportunities for that age group. They may not
Right.
go to church the way you traditionally, where you described, but they will show up to feed the homeless.
Right.
Showed
Right.
up They will show up. They will show up for service opportunities.
Yeah.
But they may not show up on Sunday for the
Yeah.
traditional sermon.
And are there boys and girls clubs in the city?
Gotta be.
I mean, I don't know. I know in Westchester there are. I don't know if there are in the city.
Boys and Girls Clubs.
Yeah.
I don't know, since COVID, I thought they did before COVID in the city. I think there was one in Harlem.
I think there still are, but
But I don't
these are
know.
things we should put on, look to see who's where. Yeah.
There's a-
Yeah.
And I also think to the point of young people showing up for service, if there's I've seen this many, many times, particularly again in the NYCHA housing centers, that when there's an initiative, to help out the old folks, like help someone, I don't know, clean their apartment, help someone move, help someone when there's an activity that involves multi-generations coming together, people will often do that. And even if young people sometimes are hesitant, that if there's an opportunity to help out, they will. And again, I'm thinking about a program that I heard about, and this was at a church in Harlem, where they actually had seniors who were living in NYCHA housing, who were completely socially isolated. I think they chose like 10 people to come in and meet with kindergartners. And each elder had like 5 kindergartners that they got to know over time. And the kindergartners got to interview them. And then they did a public event where people were invited to come and hear the stories, the history of these elders in their community, and the young people presented it. I mean, it doesn't cost much at all to do something like that. And you could do this in any public setting where you bring elders and, 20-year-olds or elders and little ones, and you bring them together to tell stories about each other. And, if you look at how global mental health, and the impact of global mental health in other countries where they very much rely on the community to help mitigate some of the crisis and the isolation that crisis bring to people, by having these communal activities can really make a difference. And it's foreign to our society, I think, particularly in New York, but it does happen, and it can happen. And it doesn't cost much to sort of join with organizations and have these sorts of multi-generational activities. And part of it is, how do we help each other, and how do we help ourselves first and then help others. And even in the senior programs, it's great that the seniors are doing better and they're connecting with each other, but planting the seed that they can also help younger people. And oftentimes the seniors have responsibility for younger people more and more, because parents are working or are not available to the younger folk, but helping the seniors to understand that they can also have an impact on the younger people. So I think there are lots of different ways that we can creatively promote this that doesn't cost a lot, but does require some organization. And that's something I think the OHMH can do.
Thank you. Great recommendations. Thank you.
I want to be mindful of time. We're at 11 right now. So it's kind of like the end of the agenda of the meeting. People who want to stick around for a few minutes, we have the room a little bit longer, but I know people have other places they need to go. We already had someone who had to leave right at 11. So thank you, Stephanie, for participating up there on Zoom. And I'm going to just kind of formally end the meeting, but for people who are in the room that want to stay, they can stay, but I'm going to stop the screen share. All right. Thank you, Stephanie.
Thank you so much.
Rachel, quick.
Yes, thank you so much for coming up here. Appreciate it.
4% of folks are reaching out to family.
Oh, yeah. Page 45.
45.